Hello, I welcome you to this lesson on our series from our series for pediatric lessons. And today we are looking at respiratory distress syndrome, or RDS. As usual, your presenter is Mr. Jones. All right, so let's define the condition under discussion today. Respiratory distress syndrome, abbreviated as RDS, is a term that is used to describe respiratory dysfunction in neonates that may be due to insufficient or deficient surfactants and is primarily related to developmental or delay in lung maturation. So, respiratory distress syndrome is more of a breathing disorder that involves the presence of two of the following within 6 hours of birth. That is, a respiratory rate which is persistently above 60 breaths per minute, and you can also have steno or costal recession, and there can also be expiratory grunting. So these are the three characteristic signs and symptoms that you see in RDS within 6 hours of birth. Okay, so respiratory rate above 60, steno or costal recession, and the expiratory grunting. What are the causes of RDS? So the first cause is insufficient surfactants in the immature lungs at birth. So surfactant is a complex system of lipids, proteins, and glycoproteins which are produced in specialized lung cells called type 2 cells or type 2 pneumocytes. So the chemical component of lung surfactants are lecithin and sphingomyelin. So the surfactant is packaged by the cells in structures that are called lamellar bodies, and it is extruded into the air spaces. So now, when the surfactants begins to be, surfactants in the life of a baby as it is developing, it begins to be made in the fetus at about 22 to 28 weeks of pregnancy, and it is found in amniotic fluid between 28 and 32 weeks in gestation. So before the baby is born, we are saying the surfactant begins to be made in the fetus between 22 to 28 weeks of pregnancy. Now, surfactant lowers surface tension at the air or liquid interface within the alveoli of the lungs. This will help to allow the lung to inflate much more easily and thereby reducing the wake of breathing. In short, surfactant helps to reduce surface tension within the lungs. It also reduces the pressure difference between the pressure difference that is needed to allow the lungs to inflate or the lungs not to deflate. So that is the function of surfactants. Predisposing factors. So predisposing factors, we are looking at conditions that uh, may predispose the patient, that is the baby, to having RDS. So one of them is prematurity. So prematurity here, the underdeveloped lungs do not produce enough surfactants, and this will result in reduced lung tension, leading to collapse of lung tissue during expiration. So our first predisposing factor is prematurity. The other predisposing factor is maternal diabetes mellitus. These babies are large for deaths, but premature with the underdevelopment of the lungs. They will fail to produce enough surfactant to prevent lung tension. So here we are looking at in maternal diabetes mellitus, we can have a large for dead baby who is born, but with premature lungs. Hence, uh, not enough surfactant can be produced to prevent lung tension. Okay, so the other thing that may predispose to RDS is multiple pregnancy. So second twin is more at risk of RDS in multiple pregnancies. So other things that may lead to RDS include precipitate labor or fast labor where baby just comes out fast and the likes. Okay, there is a fast switch of environment from utero to the outside environment. So the baby may end up having a RDS. Also, having a brother or sister who had RDS predisposes one to having RDS, or it may run like one within the family had RDS running in family, then another baby may also be born with the RDS. Okay, so other predisposition include gender. So male infants are almost 1 to 5 times more likely to develop RDS. There is a delay in the maturation of surfactant in males, and that is the ratio. That's why we have that ratio of 1 to 5 times between these two, both sexes, male or female. The other condition that may predispose to RDS is asphyxia. So this may be due to low oxygen, which leads to acidosis, and acidosis prevents synthesis of surfactants. So asphyxia predisposes one to RDS because it affects the production of surfactants. Okay, so now the other predisposition is hypothermia. So this inhibits the formation of surfactants, that is hypothermia. All right, so now let's understand the pathophysiology. So the main cause, say, the severe deficiency or insufficiency surfactant. So now, what is the pathophysiology of RDS? So as we have established earlier, it is caused by insufficient surfactants. Now, surfactant is a phospholipid lining the alveoli for purpose of maintaining lung compliance. And we have established that it is first produced at 22 weeks of gestation age, and by 34 to 36 weeks, there is enough surfactant to support extra uterine life. Now, the surfactant production must be produced continuously as it is being used. So, little surfactant will lead to alveoli collapse after exhaling. Surface tension is the elastic force that is created by a fluid that minimizes the surface area. So the lungs become non-compliant or stiff, and then they will resist expansion, thereby requiring more negative pressure. So this then may result into into severe chest retraction with each breath. All right, so the weak muscles of the chest wall are drawn inwards. This will now cause pressing of pressure on the lungs that further interferes with the expansion. As fewer alveoli expand, atelectasis and hypoxia occur, which will further inhibit surfactant production. So in addition, in utero or at birth, the baby may aspirate liquor, which contains epithelial cells. So these cells will eventually form a membrane which will line the bronchioles and alveoli ducts. That is, it will further restrict gaseous exchange because of aspiration of the liquor. Hence, the name hyaline membrane disease, it is sometimes called, okay, hyaline membrane disease, because the cells, after aspiration of liquor, the cells eventually form a membrane which will line the bronchioles and the ovary ducts, okay, that restricts gaseous exchange. So that's why they call it sometimes hyaline membrane disease. Okay, so now that is just a brief pathophysiology. You need to know is the sufficient surfactants there that will lead to RDS or respiratory distress syndrome. Now, what are the clinical features of the patient with RDS? So you may see nasal flaring, which is due to difficulties in breathing, Cyanosis can be observed, which is due to anoxia. There can also be acidosis, which is due to impaired gaseous exchange. Chest retraction, that is pulling in of the lips and sternum during breathing, can happen. That may even create a negative kind of tension. Then apnea, that is very small preterm babies have irregular slow breathing and apneic spells. So apnea, absence of breathing, may be observed. Okay, so it's also possible amongst the clinical features to observe grunting respiration, which is an audible noise that is heard on expiration. This sound appears when there is partial closure of the epiglottis as the baby's breath is expired. So that's why that noise that grunt is heard. So otherwise, the baby attempts to preserve internal pressure in the lungs and always from collapsing at the end of the breath when they are facing this. Tachypnea. So tachypnea. So this is a compensatory rise in the respiratory rate that is initiated in the respiratory center. The respiratory rate is above 60 breaths per minute. So because of the blockage there, the glottis and the likes, right? So we said granting respiration, the baby attempts to preserve internal pressure in the lungs and airway from collapsing. Hence, a compensatory mechanism of tachypnea will develop, and this is a compensatory rise in respiratory rate that is initiated from the respiratory center within the higher centers of the brain, and the respiration will now be above 60 breaths per minute. All right, so the patient may also become lethargic, and usually the baby will lie on the displayed position due to prematurity. Okay, so let's now look at assessment of the child with respiratory distress syndrome. So there's this assessment which we call Silverman's retraction scoring, which is more of a system for evaluation of breathing performance of premature infants and neonates with the RDS. Like the APGAR system, it evaluates 5 parameters and assigns a numerical score for each parameter. However, unlike the APGAR score, the lower the total score, the better the neonate. That is in the Silverman-Anderson system. All right, so the best score possible within this category is 0, and the worst is 2. Parameters assessed are retraction of the upper chest, lower chest, and xiphoids, nasopharynx, and expiratory grunt. So those are the parameters that are assessed. All right, so this is how the Silverman score looks like. All right, so we have a column for score, and then we have the scores 0, 1, and 2. And then we have rows where we have upper chest retraction, lower chest retraction, the xiphoid retraction, nasopharynx, and expiratory grunting. And we said 0, the baby is better. The higher the score, the worse the child is. So when you look at this from above upper chest retraction there, we are saying it needs to be synchronized, and then there should be lag in inspiration and seesaw movements. And then when you go to expiratory grunting, none, stethoscope only, and then naked eye and ear. So within the score there, or within the scores or things that you have to score, we have these parameters. So you have to follow row by row. When you go to upper chest retraction, you check under 0, there's synchronized. Under 1, there's lag on inspiration. Under 2, there's the seesaw movement. You go again to the next one, which is lower chest retraction, where under 0, there is none. So then, okay, like under 0, it's better. Under 0, it's better. Under 0 is better. Then under 1, we have just visible, minimal, or stethoscope only, going downwards like that, the column. And then under 2, We have marked in the other part and marked, and then that is naked eye and ear at the bottom, where we have expiratory granting underscore number 2. Okay, so this can also be looked at in this formatting, okay, so that we have a good perception of it. So we have grade 0, where in the scoring there, upper, that is grade 0, grade 1, and grade D2. So we have on top upper chest, and then the lower chest, and then the xiphoid retraction, the nares, the dilatation, and expiratory grant. So under one, the scoring will be synchronized. Okay, lower chest, there will be no retraction. Then xiphoid retraction, there will be none. Nares dilatation, there will be none. And expiratory grant, there will be none. All right, so if you would allow me to just jump to the number 2, which is the waist score, and under grade 2, we have under upper chest, we have CISO, then the lower chest, we have which we have marked lower chest, and then under xiphoid retraction, it is also marked. Under nares dilatation, you see it is marked, and then expiratory grant, it's in naked ear, or can hear it by naked ear, no, can hear it with the naked ear. All right, then we have in the middle for 1 with those calls from lag on inspiration, just visible, then minimal, then stethoscope only. You are able to hear the expiratory grants. Okay. All right. So now, how do you diagnose this condition? So history from the mother on gestation age to rule out preterm is very important. Okay, our history, rule out diabetes, large for gestation baby, and all those things. So history taking is very important. After that, you can do a physical examination on which it might review signs and symptoms of prematurity. Okay, so since we're looking at RDS, I would also encourage you to look at the other lesson we recorded on prematurity, so that you can also capture and see what are the signs and symptoms of prematurity. Okay, so on auscultation of the chest, air entry will be diminished with the crepitation. And the next layer will review an under-expanded chest and find lenticular granular, that is rice grain appearance of both lung fields may be noted. Blood gas analysis reviews hypoxia and excess acids in the blood fluids, which results in respiratory or metabolic acidosis. You can also do a dextro stick test, and it is done to rule out hypoglycemia. So before the delivery of the infant, there is a lecithin-sphingomyelin ratio that can be done, or LOS ratio, which is done, and it helps to assess prenatal lung development and RDS risk. So for the RS ratio, if the result is less than 2 to 1, then the fetal lungs may be surfactant deficient. Okay, so now let's look at management of RDS, respiratory distress syndrome. So how is its management? So the aims of our management is to maintain respiration since the patient has breathing problem. Then the other part of our aims is to prevent hypoglycemia, reduce or reverse metabolic acidosis, prevent hypothermia, prevent complications such as metabolic acidosis. All right, so what is the immediate care? So this one requires urgent care, so urgent care or immediate care. So what is our immediate care? Since without intervention for a long period of time, the baby can be lost. So it's an pediatric emergency. So immediate care, this will depend on the severity of RDS as determined by arterial blood gases. So dry and keep the baby warm in order to preserve the baby's warmth and maintain patent airway by suctioning gently to prevent trauma. You can also administer oxygen through head box, that is 30 to 40%. This is to help keep baby pink and monitor for oxygen tension. All right, so oxygen is given with a small amount of continuous positive airway pressure. This is to help reduce the concentration of carbon dioxide in the blood. So if the baby's condition worsens, an endotracheal tube is inserted into the trachea and intermittent breaths are given via ventilation. All right, so now there is also a base or sodium bicarbonate that is 4.2% or 8.4%, 1 ml per kg body weight that can be given because baby is at risk of respiratory acidosis, okay, or metabolic acidosis. So we can give sodium bicarbonate. Vitamin K, 1 milligrams per kg body weight. This can help to control bleeding tendencies, especially that the type of client that is predisposed is a premature baby who may not have developed fully the clotting factors. So vitamin K, that is 1 milligram per kg, helps control the bleeding. Antibiotics such as benzylpenicillin, that is 50,000 international units, can help prevent secondary infections or preventing infections. Okay, the baby is prone to a lot of infections because of compromised airway. So it's important that the antibiotic cover is given. So before delivery of the infant, corticosteroids are administered maternally to stimulate production of surfactant in fetus. That is at high risk preterm birth. E.g., dexamethasone can be given. Okay, so that is before delivery of the infant. Corticosteroids can be administered. So IV fluids can be given as follows: 10% dextrose for nutrition, half strength Dallos solution for maintenance of fluids and electrolytes. Then intravenous fluid and sodium bicarbonate are administered to stabilize the blood sugar, blood salts, and blood pressure, and control acidosis and maintain fluid and electrolyte balance. So that's the reason for ensuring sodium bicarbonate, although I've already stressed this. Administration of surfactants. So if you are working in a setting where you have surfactants there, so severe cases are also treated with surfactants, which is similar to one that is found in the lungs. So this drug is infused into the lungs through a very thin tube in the baby's trachea. So the most common use surfactants preparations are SPB and SPC. So this treatment reduces the risk of lung rupture, and within a few days, the infant is usually breathing more easily. So sometimes babies who are born prematurely but without signs of RDS are given the surfactant drug as a preventive measure. And infants who respond to treatment for RDS generally recover with no lasting effects. However, if the condition is not treated, lack of oxygen will damage the body's major organs and their function will be disrupted, which may result in death. Okay, so now let's look at the nursing care of this condition. So nurse the patient or the infant in the incubator and should be cleaned with acceptable temperature to promote recovery. If the incubator is not available, baby to be covered with warm linen to help maintain body temperature. The environment must be safe from hazardous equipment and microorganisms to prevent injuries and infection, respectively, and it should be well dusted also for infection prevention. The environment must be quiet to also promote rest. what psychological care can be given. So you have to explain the disease process to the parents and allow parents to participate in the care to promote bonding. Also, it is important that you explain the functions of respiratory devices and equipment that you are connecting to the baby. It may also be very scary for the mother and they may look at it as more of traumatizing the baby. So it's important that they understand the function. Inform parents that recovery may take long and reassure them without actually giving false hopes. It's also important to allow parents to ask questions and respond possibly as it helps you to gain cooperation or their cooperation. Observations. So you can monitor arterial blood gas levels by use of a pulse oximeter to monitor saturation of oxygen levels. You can assess skin color regularly to note improvement and effectiveness of oxygen therapy or ventilator. It is also important to assess the rate and depth of respiration. So when you can assess severity of retraction, that is chest indrawing, nasal flaring, frequency of respiratory grunting, and restlessness. You can observe for signs of infections too. So frequent observations of temperature, heart rate, respiration, and color of the skin is very, very important in this patient. So temperature of the baby is taken rectally at regular intervals of not less than 4 hours to, to detect hypothermia. Baby are at risk of hypothermia. So when you're giving some 10% dextrose there and the likes, is to encourage metabolism of carbohydrates or glucose so that heat is generated. So normal temperature should be maintained in the normal range that is between 36.5 to 37.5, and the temperature of the incubator should be between 34 and 37 or that of normal body temperature depending on the baby's condition. Now let's look at fluid and nutrition. The fluids, electrolyte, and calorie requirement is supplied by intravenous infusion. This should be continued until the baby's condition has improved to allow oral feeding. So when oral feed starts, it is very important to use a cup or spoon to prevent infection. When the baby starts sucking, the mother should allow the baby to suck as much as possible before she gives her feed by the cup. Okay, so in the other lesson, we looked at hypoglycemia and hypothermia. So now you can always watch that lesson that we've already recorded and posted on how you can prevent hypothermia. But otherwise, some of the points to note here is that the baby should be kept warm either by use of incubator or wrapping the baby in warm clothing. So when the baby's condition improves, kangaroo care is the best. That is, the room temperature should be monitored, where put the baby near the mother or touching more the baby to the mother's skin or abdomen so that the heat that the mother is generating is transferred to the baby. So that's what we call kangaroo care. Okay, kangaroo care, like hugging the baby so that the heat that the mother is producing is transferred to the baby's kangaroo care. Hygiene, do top and tail. This is to prevent the baby from going into hypothermia. So you clean the face and clean the perineum area. So that's what they call the top and the tail. You can change so the nappies here to promote good hygiene, and it's also good for the baby to prevent infection. So provide mouth care every 2 hours and do eye care to prevent infection. Prevention of infection. So in RDS, prevention of infection, what we can say is that frequent and effective hand washing is important. We're talking of reverse barrier nursing because baby is prone to getting infection from the staph. So there should be what we call reverse barrier nursing because the patient is prone to infection. So maintenance of high standards of care at all times is important in order to avoid infection coming to the ward. There can be restriction of visitors and personal handling of the infant, and literally normal practice. It's only the mother or the father that can be allowed. So here we do not have big groups of people that are coming to visit the whole compound because the baby is prone to infection. So I've already stated that reverse barrier nursing here can be used, and because the patient is prone to catching infection. So other skillful things like resuscitation is needed when attending to clients with asphyxia so that it does not develop into RDS. And good antenatal management to screen mothers with high risk conditions such as diabetes mellitus and hypertension is important so that uh, the necessary measures can be taken after the baby is born. So for anticipated cesarean section, administration of dexamethasone to the mother prior to delivery can help in actually the production of surfactants of the fetus. So it's important to avoid prolonged labor as it predisposes to birth asphyxia and also avoid giving drugs such as pethidine uh, 4 to 5 hours before delivery because it depresses the respiratory center, leading to asphyxia and later leads to RDS. The respiratory center of the baby. Hence, the baby also because it's going to cross the placenta affects the baby, and the baby becomes a little bit drowsy, so baby will forget to breathe. So women with the incompetent cervix should have Shirota suture inserted to prevent preterm labor or going in labor early. All right. So let's look at now complications of RDS. So one of them is respiratory acidosis, which we have stressed within the discussion. This is mainly due to poor exchange of gases in the lungs. And then we can also have metabolic acidosis, which is also due to hypoxia, and they use anabolic actually metabolism here. So atelectasis, that is due to the lack of surfactants, may also be seen, and intracranial hemorrhage, that is due to hypoxia, can be seen, and retrolento fibropressure, which is actually a side effect if on oxygen for too long, the baby may have what we call retrolento fibropressure. So mostly may come from oxygen administration. Okay, so infection that is due to immature immune system can also be seen. Mental retardation that is due to brain hypoxia that is leading to brain damage can also be noticed. Okay, so now pneumonia due to aspiration of meconium and secretion can also be noticed or can be observed as one of the complications, and then we can also have neonatal jaundice, which is due to inability to conjugate bilirubin. So I thank you most sincerely for listening to our lesson on RDS, respiratory distress syndrome. Please click in the comment below this video so that you tell us there are other lessons that you would want to learn or where you're finding challenges so that we can explain. So thank you very much for listening, and I'll see you in the next lesson.